give them 30 more seconds and we can then get started. All right, let's get started. My name again is Nirmala Ravishankar, and I'm a senior fellow at ThinkWell. I'll be hosting the discussion today about direct financing for health facilities. Thanks all for joining. Many of you have probably noted that this concept has been attracting a lot of attention lately. Indeed, there's a growing consensus that granting health facilities in the public sector more funds and greater autonomy is critical for improving service delivery. It also seems necessary if you're going to talk about using payment methods to send signals to providers. This was one of the themes highlighted by the Lancet Commission on PHC financing. There have been several papers on this topic recently, including by WHO and the World Bank. Having said that, it's worth noting that this idea is not new per se. The notion that we should grant health facilities, especially hospitals, more autonomy over finances and operations has been around at least since the 1980s, when discussions around new public management first started. And thinking, of course, around different management models for healthcare predates all of that. So a key goal for the discussion today, and why I made reference to all the fuss in the title of the webinar, is to better understand what this concept is and why all the buzz now. It's also worth recognizing that not everyone is convinced. Some feel that local governments are better positioned to manage service delivery. Is it realistic or frankly desirable to expect each facility, especially small health centers or rural health units, to maintain detailed accounts and procure commodities, etc.? So in the discussion today, we will be talking about why some are fussy about giving facilities more autonomy. So to get into all of this, I have two extremely thoughtful and wonderful health financing specialists joining me. First, we have Sheila O'Dougherty, who, of course, needs no introduction, but I will try nonetheless. Sheila is an expert in health policy, health system strengthening, health purchasing, and provider payment, just to name a few areas. She retired as vice president of Abt Associates in 2020. She's worked for over 30 years in international development, including leading large programs in Central Asia and Tanzania. And indeed, the program in Tanzania was about providing support for a large-scale reform to enable direct financing for service providers in the health and education sectors. Sheila is also the lead author of a joint WHO World Bank brief on direct financing for facilities. We also have with us Edwine Barasa, director of the KEMRI Wellcome Trust Research Program in Nairobi, Kenya, and a visiting professor of health economics at Oxford. He has a PhD in health economics from the University of Cape Town, and his research interests include equity and efficiency analysis, economic evaluation, measuring health systems performance, governance, etc. He was instrumental in documenting how health facilities lost autonomy when Kenya embraced devolution reforms about a decade ago, and he's published extensively on this topic. He's served on multiple task forces in Kenya to shape that country's health financing policy, and also worked extensively in the region. So I want to thank you both, Sheila and Edwine, for joining. Edwine, especially you for agreeing to join today, despite being a little under the weather. So at some point, if you need to turn off your video or anything like that, we will all understand. Before I dive right in, I want to thank two of my ThinkWell colleagues as well. The first is Caroline Mohan, our communications manager. She's been instrumental in setting all of this up. She will also be recording today's discussion and sharing the video with all of you by email, and indeed with others who couldn't make it. So please note that the session is recorded, but as an audience member, your name and other details will not be recorded, including if you post questions. The other person I want to thank is Gillian Turner, who's a technical director at ThinkWell, working primarily on the strategic purchasing for primary healthcare project. Gillian has graciously agreed to monitor questions and comments posted online, and to select a few to pose to our panelists. So keep those questions coming by using the Q&A box, the question and answer box, which you should see at the bottom of your screen. We'll try to get to as many of those as possible. As I noted when I began, we want this to be a free and frank discussion. We may not all agree on everything, but we all agree that we benefit from exchanging ideas openly and respectfully. So with that, let me get started. Sheila and Edwin, thanks again for joining. I'm of course going to pose questions to you, but this is really a discussion, so do feel free to respond to each other. I do apologize up front if at some point I have to interrupt. We only have an hour and a lot to get through, but I promise not to be too rude about that. So in this first segment, which I'm calling Why the Fuss Part 1, is this a new idea or an old idea whose time has really come? Let me start with you, Sheila, with a simple question about definitions. What is direct financing for facilities? Is it a payment method? Is it a new scheme? Is it a set of reforms? Over to you.
Hi, good morning, I guess afternoon or evening all. It's nice to be here. Thanks a lot. I will reference the WHO paper with the World Bank that Jillian nicely put in the chat. Direct facility financing includes 3 principles that are generic, foundational, and flexible enough for any country to adapt to their own environment. The principles are facility autonomy, use of output-based payment, and facility accountability for good financial management, including the use of extended or newly introduced facility financial management system. It can include any kind of revenue, but one key aspect of the definition is that it includes at least some general revenue. To get to the heart of health financing and UHC, cross-subsidize the poor and underserved populations, support equity and financial risk protection goals. In parallel, and also very importantly, this ensures that funds are institutionalized into country PFM systems and not separate or fragmented, which is less efficient and sustainable. This integration is not easy, and it often involves the creation of a new intersection of health financing and PFM, but the return on the investment can be great. Direct facility financing, or financing facilities directly, is not a scheme or a tool, an application, a menu, a brand, but rather a set of attributes in action. It definitely includes provider payment at its very heart, and it can be part of either broad reforms or continuous improvement processes. Over.
Thanks, Sheila. Thanks so much for that succinct but informative overview. Edwin, your thoughts on this definition and key principles, and to keep this conversation moving, why do you think there's been so much discussion about this topic recently?
Thanks, Nirmala, and thanks, Sheila, for that elaborate, definition of the concept of direct facility financing. I mean, fundamentally, I think it makes a lot of sense, and I see direct facility financing as really mostly around funding flows and provider autonomy. And what I mean here is that when you think about the counterfactual to direct facility financing, there's a lot of experience of health facilities, especially primary healthcare facilities, not receiving, the funds that they're supposed to use to carry out their functions and to be able to deliver services. And so what direct facility financing does is to really think about funding flows and think about how do you ensure that, from the source of the funds, you ensure that funds actually get to facilities. But then that is not useful if then facilities do not have the autonomy of the decision rights to be able to make decisions around these funds, because these funds are supposed to do something at the facility level. So that's what DFF is to me. It's about reforming funding flows so that funds get directly to facilities, and also ensuring that the facilities have the capacity or the decision rights to be able to make decisions at that level. Now, in addition to that, then we have to ask ourselves, well, how do we make direct facility financing work? What are the design features of DFF that will enhance, its effectiveness in terms of the kind of outcomes that you're interested in? And this is where now things like, what are the features of the provider payment mechanism? What are the provider payment mechanism arrangements? Are they output-based? Are they input-based? We know that it's best if they're output-based. What accountability mechanisms would be required to ensure that we get what we get from direct facility financing. And here we are talking about both internal accountability mechanisms, so the reporting and so on, but also external accountability mechanisms, because what facility autonomy and DFF allows is to provide opportunities for sort of public or community oversight as a potential mechanism to strengthen the use of funds and so on. And then also PFM capacities. You will need PFM capacities if you are to ensure that DFF works the way it needs to work. So I see these things that I've described as design features of DFF rather than the definition of DFF on its own. Now, in terms of, I think you've asked, why is it garnered attention? I mean, I'm sure there are many reasons why there is increased attention to DFF. The ones that are sort of top of, for me at least, top of the list is one, performance-based financing experiences. I think, Global Health has experimented with PBF for a while now, and there has been questions around whether PBF works or not, and under what context does PBF works, and so on. And more importantly, DFF has emerged as a sort of counterfactual to PBF, as something that people have seen as sort of the active ingredient that is in PBF, and not just the incentive component of PBF. So I think the experience with PBF has led to increased attention to DFF, but then there's also attention to PHC financing, attention to PHC performance in general, and then PHC financing as a lever for PHC performance, where it has become clear that if you are to improve PHC financing, you have to think about whether public funds are getting to these facilities, and you have to think about whether these facilities have capacity to make decisions over these funds. Over.
Thanks, Edwin. I want to come back to this capacity question and concerns about that capacity in a minute, but Sheila, I wanted to see if you want to come in on this issue of, is it DFF versus PBF? I feel like certainly in some of the research that we've seen coming out of the bank from a few different countries in Africa, these two models are presented as alternatives or contrasts, and in particular, DFF is presented as something that's simpler or less conditional. Is that how you see it, or do you see these as complementary? Maybe as Edwin put it, is the DFF piece the active ingredient even in the PBF piece? So over to you, Sheila, to talk about this distinction people draw between DFF and PBF.
Yeah, I mean, maybe you could say that direct facility financing is less conditional, but I guess I probably see it as more a question of whose conditions. Financing facilities directly using general revenue funds and country PFM systems might be more about country conditions than development partner project conditions. And yes, it's definitely intended to be more about principles than conditions. Principles applicable and adaptable to priority problems, legal, operating, and cultural environments in any country. I'm not sure exactly what it means to say it's easier. You can probably argue it either way. But to me, direct facility financing, kind of what Edwin was saying, is more foundational. The heavy lifting that enables additional targeted incentives on top to leverage all the funding. The optimal relationship might be to build PBF on top of the basics of financing facilities directly. However, as also mentioned, it's also true that in some countries, RBF or PBF has triggered facility autonomy, which does support financing facilities directly. So there is obviously a relationship. Maybe it's worth thinking about the variable of time to design and time for sustainability. Financing facilities directly might take more time to establish on the front end, to integrate into country systems, but be more sustainable on the back end. Patience and time is often not something that development partners have these days, but it is critical. And definitely would encourage DPs to invest enough time to find ways to integrate into country health financing and PFM processes. One of the things I think that has seemed to become clear during the discussion is that most countries would be better served by moving away from two parallel extremes. One, a rigid input-based payment system, and then second, whatever it's called, pay for performance, RBF or PBF, it has a fee-for-service type of output-based payment, which contains strong and direct financial incentive. I think on average, the relationship or the thinking is moving towards a pyramid with some remaining underlying input-based payment, for example, for salaries, at least in the short term, to a core output-based payment systems in the middle, to PBF on top to stimulate and leverage all the funds. That's the critical point, not just the project funds, all the funds. In most cases, it's optimal for the core output-based payment system to be formula-based rather than flat fees so adjusters can meet goals and objectives like need and equity and performance. That then allows PBF to be embedded in the formula to ensure performance incentives, but also a comprehensive framework and less fragmented approach to purchasing basic benefit package services. So in summary, I think there's very much a complementary relationship and would not feel like this is a competition. But I do agree with Edwin that, the core basic umbrella down there at the bottom is probably more what has been termed direct facility financing than PBF. Over.
Thanks, Sheila. And hearing you speak, I just feel like perhaps there's also a need to clarify when you say output-based financing. I wonder if that term means different things to different people. And you're, of course, someone who's worked a lot on provider payment. I think in the sort of literature contrasting DFF and PBF, the PBF component has been associated with, or the PBF model has been associated with measuring every output and paying based on that and verifying those outputs. Whereas I hear you saying that that's more like the fee-for-service model and we could move to a formula-based model. So could you speak a little bit, when you say output-based, you're basically contrasting it with input-based. Is that fair? Is that a fair characterization?
Correct. I would think about it, not to go on too long, but I would think about it as input-based versus output-based. Input-based paying for the inputs to an output, output-based paying for the output. And exactly as Edwin says, I mean, by definition, I think that was another question that has come up before. By definition, when you go to output-based, there's no more dancing around whether the facility has the autonomy to determine the best mix of inputs. They have that autonomy. But within output-based, like any kind of generic engineering discipline, really, it's a discipline to design the best output-based payment system. And there's a continuum of them. There's many types. And I do believe this is something that the field should generally be more aware of. And there's many ways to characterize them, but I would think in terms of bundling. At the very heart of the type of payment system is how much you're bundling the services, because that determines the risk sharing between the purchaser and the provider. At the far end of one is complete unbundling down to every service or procedure. And often PBF is focused on this type of fee for service because you want a very strong incentive, which is great. And then on the other side might be the primary healthcare per capita payment to pay for all the services at the primary healthcare level. The point is you can do both. And you can do both by having a formula where it might be for primary healthcare facilities, the core base rate times the number of people served. But then you have elements, you have mathematical elements that are embedded in that formula. And you can certainly include these performance elements in the formula so everybody can look at the comprehensive formula and you're not distorting things by every facility only focusing on the services that are being paid extra fees. So it is a complicated story what output-based payment is, but it is absolutely an underlying inherent principle to the extent that if a country is considering extending input-based funding under direct facility financing to the service delivery level, I would say to the providers, hey, don't sign up for that. That's a trap. You're going to get all the problems they had with none of the flexibility to solve them and no way to piece this together and better deliver outputs for your clients.
Fair enough. Thanks so much, Sheila. Edwin, so in Kenya, of course, the idea of direct facility financing has been around for a while. There have been ups and downs, as you've documented in a lot of your writing. What's the situation right now? Is it stock up or down? What's the current feeling?
Thanks, Nirmala. I mean, so the short answer is that, it's mixed. And it's because of the story, right? I mean, before devolution, I think everyone was absolutely convinced that it makes a lot of sense for funds to flow directly to facilities and for facilities to have autonomy. And here, when I talk about facilities, I know when you talk about DFF, we mostly focus on primary healthcare facilities, but I think, it incorporates what we do with hospitals, because especially first level referral hospitals face exactly the same challenges. So before devolution, everyone was quite convinced that it makes sense for facilities, both hospitals and primary healthcare facilities, to get direct access to funds. At the beginning of devolution and our experience over the past 10 years, it has been one of at the beginning, there was a lot of resistance to facilities, funds flowing directly to facilities, and facilities having autonomy to spend those funds. So had a lot of resistance at the beginning for multiple reasons. I mean, one, of course, we have a PFM Act that kind of made that difficult, and instead shifted that control to control over resources to the local government, so the county, as opposed to health facilities. And second, there is a political dynamic of county level actors pulling and pushing with health facility managers over control of resources. So a lot of resistance at the beginning, but we've had the experience of what it means for facilities not to have this autonomy and direct flow of funds. And the experience hasn't been great. I mean, it's been clear that it's compromised facility functioning in multiple ways, in terms of human resource motivation, in terms of leadership capacities within facilities, in terms of accountability, both internal and external, availability of commodities and basic facility functionality, and so on. And so what we are seeing over the past 2, 3, 4 years is increasing support for autonomy and funds flow directly to facilities. So lots of efforts to take that autonomy and direct flow funds to facilities back to facilities. So at the moment, I would say the stock is slightly up. There's still some resistance, but certainly among technocrats, the stock is up. Amongst politicians, it's mixed. Some politicians are supportive, or rather some actors at the local government level are supportive. Some are still not so sure they would want to give that support back to, control back to facilities. So mixed, but better than 10 years ago.
Perfect, thanks. It also seems to me that, in Kenya and in other places where this mechanism is being introduced to compensate facilities for user fees, it's accompanying a policy to remove user fees, then, user fees for all their issues are direct funds that go to the facility, give the facility a lot of control, and it's paid right on time. And so when you're replacing that with a mechanism from the central level to compensate the facilities for lost user fee, that ensuring that flows on time and is sufficient seems even more important. And so with that, I want to kind of segue to talking about some of the potential risks or challenges that we can anticipate with this arrangement. And Sheila, I want to kind of get to this one common criticism that one keeps hearing, which is that, hold on a second, how do we expect these, especially primary healthcare level facilities, to have the capacity to receive manage and account for these public funds? Wouldn't it be better, Sheila, to give the money to the local governments that are set up to do this and have the local government manage a network of facilities that are within their jurisdiction? Thoughts on that critique?
Yeah, I guess let me go on a little bit more in this one, or a slightly longer response, because I'd like to unpack that. You know, first, as a kind of, you know, it's important, I think, to understand that part of that definition of direct facility financing, underlying it, and some of the things that is new about it, is a focus on management. A lot of this is about management. Basic management, and it's not, you know, that is not the same as public health or clinical medicine or economics or finance. It's a lot about management, and this focus allows differentiation of governance and management. They are related, but they're not the same thing. It helps to illuminate that local governments or government apparatus or a town hall is not the same thing as a public service provider like a health facility or a school. There's an opportunity to unpack the details and look at the functions and tasks to differentiate things like oversight, certainly a governance responsibility, and day-to-day operations, which is more on the management side. And again, both local government and service providers have important roles that should be identified, appreciated, and improved. I would also like to place this question in the broader context of broader health financing on the road to UHC. Pooling, particularly pooling, but also purchasing arrangements are critical for efficiency, equity, financial risk protection, and UHC. So this isn't only about local governments. This is also about national governments and pools, and the idea that at some point for risk protection, you need some centralization of financing, and therefore then decentralization of management, including to service providers. I think it's also really important when looking at this, is it local government or service providers, is that it's good PFM practice. The kind of still the number one rule of good PFM is separation of functions. Financial functions, authorization, and payment, they can be separated across local government and service providers. Now, on capacity, this question always comes up. And the debate is always tricky or political or ideological or philosophical. I mean, you really can't prove anything here. It's a lot of matter of beliefs. One side of the debate tends to make the case that providers, including primary health care facilities, should be unleashed to manage and perform. The other side is primary health care facilities must be either controlled or their capacity built for years. I definitely can make a powerful argument that the most likely outcome when primary healthcare facilities are unleashed to do what they were meant to do is that they will step up and manage delivery of financing and services. But someone else can make the argument that they will not step up and need to be closely controlled. But I do believe it's time to hit this head on and ask questions like, why would we believe that an entity that was established to perform a function, produce a product, or deliver service is not capable of doing it? And the human nature element comes into play, the involvement of providers for motivational and performance reasons. It's really human nature. Quickly on the specifics of capacity building, of course, continuous capacity building is critical for most things in life. And my experience is that on-the-job training works best in concert with actual policy change, bank accounts, money flowing, and installation of management systems. It's human nature. People begin to believe and trust that it's actually going to happen. Tanzania did take a creative step that could be explored in other countries, which is to set up an IT desk. Just like in private companies, you can email your IT problem and get a ticket to address it. This could be a great role for regional or local governments to support their providers. Last comment on accountants and accounting. Basic cash accounting is not that complicated. We all do it in our own households. In the short term, perceived requirements for accountants should not undermine direct facility financing. Nurses and other staff can play this role. They're motivated and they're able to perform this function to help serve their patients. But they need financial management and accounting systems, and not just extension of top-down IFMAS, which is really cash management and monitoring for the country, but systems appropriate for facility level management. In the longer term, there are definitely options to establish the financial management and accounting functions. For example, facilities can share an accountant or outsourcing. So a long answer, but really breaking it down to this question of local government or facilities, which is the story is kind of both, and they both have critical roles. And the capacity story often comes down to this kind of more belief on whether you should unleash or control providers. Over.
Thanks, Sheila. Edwin, you're a researcher, you look at the evidence. I mean, there will be people who will sort of have ideological positions on this question, but in terms of the evidence about giving facilities greater funds and more autonomy, and that leading to better service readiness or outputs, what does the evidence tell us? And if you want to kind of differentiate between what we know about hospitals versus health centers, please do, because I know you've looked at both.
Thanks, Nirmala. I mean, I think I'll link that to it's somewhat linked to the discussion you just had with Sheila around the issue on capacity. What does it mean for primary healthcare facilities, small facilities at the peripheral level, getting all these responsibility with sort of questionable capacity? And I do agree with Sheila. I mean, I think in many ways the issue of capacity is distraction in a way, and I say this because what we need to be convinced of is whether the fundamentals of what we are talking about, whether sending funds directly to facilities and giving them autonomy is a good thing or not. And by a good thing, I mean, does it strengthen service delivery? Does it strengthen facility facility functionality? Does it advance the health system goals that we're interested in, equity, efficiency, quality, and so on? That's what we need to be asking ourselves, right? And if we are convinced that it's a strategy that can work under the right circumstances, then we need to ask ourselves, what are those right circumstances? And if one of those is capacity, then we need to make sure that these facilities have the capacities that they need. If they need financial management system, that's what they need. If they need adequate numbers of or rather, support in terms of staffing for accountants and so on, we need to make sure that that's there, as opposed to giving that role to the facility manager and then coming back to say the facility manager is overwhelmed by reporting requirements. So we need to basically figure out, is it something that is a good thing to do? And if it is, what do we need to do to make it work? And that brings me to the second question around, so what's the finding out there in terms of the effectiveness of direct facility financing? Again, I think there's more information, or rather, there's more evidence at the hospital level and emerging evidence at the primary healthcare facility level. And across both, you have mixed findings. You have instances where the data shows that providing autonomy and ensuring funds are in facility bank accounts and they have control over it and so on will improve health worker motivation, for instance, enhance facility accountability, because you need to create those accountability mechanisms, ensure that you have improved availability of health commodities. The fact that it's direct funds to facilities also improves the timeliness of funds flow and improves basic facility functionality, just making sure the facility is actually running and so on. But then you also have, on the other hand, evidence that shows, well, autonomy was implemented and none of these desired outcomes were actually observed. And sometimes you also have instances where you have undesired outcomes. So we have depending on how these reforms are structured, and especially when you have a combination of that and user fees, for instance, sometimes you can have a prioritization of facilities prioritizing high revenue generating services because they see that as they essentially incentivized to try and generate as much revenues as possible, and that tends to compromise services that are not high revenue generators, and PHC gets to suffer in that effect, in that instance. And then, of course, if you don't carefully think in instances or in cases where accountability has not been carefully thought of, then you have compromised accountability. So, Nirmala, the question for me is not really whether it works or not. I don't think that we should stop there with complex health system interventions. The question is really, under what conditions and in what context does it work? So really understanding the interaction between the design features of the reform and country contexts and the conditions under which these reforms are being implemented. So understanding that is quite important, because then it provides you with leverage points for ensuring that you're structuring these reforms in a way that promotes the outcomes or effects that you're interested in.
Thanks so much, Edwin. So it almost sounds like we should, rather than trying to ascertain whether this is a good idea or a bad idea, or whether it works or not, but rather see under what conditions, right? Because we're all sort of convinced that you need various enabling factors, whether it's capacity or indeed accountability. How do we, or how are different countries currently setting these arrangements up and making those kinds of design choices? So thank you both for that. I wanted to quickly, in a couple of minutes, also get your thoughts, and I know this is not a question that can be easily tackled in a couple of minutes, but I will try, on the politics of it. So, Sheila, your comments about it's not just about local governments, it's also about centralizing funds and pooling at the national level. And then certainly at the local level, if funds are being earmarked for facilities, isn't there a chance that local governments will see this as either re-centralization through the back door or money being taken away from them and given to the facilities? And so I just wondered, and I'll pose this question to both of you, maybe starting with you, Edwin, this tension, especially at the local level, the political aspects of it. And Sheila, for you, how did Tanzania kind of manage that political tension? How was this reform, to put it bluntly, how was this reform sold to the districts in Tanzania so that they went along with this and didn't see this as money being taken away from them? So really quick responses from you, Edwin, and then Sheila.
Thanks, Nirmala. So the short answer is politics does matter, and it does play a very big role in whether there is buy-in and support for DFF as a reform. So whether there is support for DFF as a reform, depends largely on politics and managing the politics around it. So that's one thing. Second, we need to have a bit, the discussion around the role of politics and the tension between, especially the tension between the local government and health facilities, needs to be slightly more nuanced. And I say this because governance structures across countries differ. We have countries that are largely centralized. So, largely centralized. And even within those countries, you might have decentralization within the health sector, but it's the sort of less intense forms of decentralization. So delegation of functions to local government, so to districts and so on, or deconcentration of functions. So you have that on the one extreme. And then on the other, you have countries with extreme forms of decentralization, so that you have a local government that has political roles and responsibilities and functions, and has direct service delivery functions allocated to them as opposed to the national level. So countries where you have devolution, for instance. In the latter forms of of governance arrangement, then the local government not only has sort of an increased role in the health sector, in terms of not just delivering services, but also mobilizing resources and managing, human resources and so on. But they also have an increased interest in control over resources, right? In control over resources and where the power lies with regards to control over resources. So in instances like that, then there is huge tension, because what the local governments would prefer, at least in the experience we've seen, in the experience we've seen in Kenya, is that they have control over where the funds go, how the funds are used, and so on. But in instances where local governments do not have that much authority, then the political interest and the interest over control of resources is actually tipped in favor of health facilities. And we see that in a number of countries. Again, in Kenya, before devolution, there was never an issue of local government interest, because districts did not have that kind of leverage to start arguing for controlling resources in place of facilities. So you have to discuss the role of local government and political interest within the context of the governance arrangements within countries. And so I would imagine, for instance, that in Tanzania it will play quite differently, because they're not a devolved system of governance, for instance. But over to Sheila.
Sheila, any thoughts on this? Is it easier to achieve if you don't have devolution to contend with?
Well, this is very tricky, and I don't want to, I guess I'm going to qualify this very clearly. I'm not arguing with Edwin about it, and I don't want to overly compare Tanzania and Kenya. But in Tanzania, there were some basics that were accepted from the presidential and national government level all the way down to the local government level as part of the decentralization by devolution. Tanzania also has devolution. But these basics were that public services must work for the population, full stop. Health facilities and schools must function. And that ensuring that they function is a role of everyone. So there was a heightened visibility on that. Not just, oh, it's local government's responsibility. It was, they must function. And that led to a recognition that they are not the same thing as local governments. So that is important to recognize, but also particularly important is the PFM rules, basic public finance management, which requires a separation of functions everywhere, not just the national level needing transparency and, bluntly speaking, anti-corruption, it's local governments too. And when you can better separate the functions and involve the facilities and have more transparency, I mean, that was basically seen as a good thing. So now to comment on some specifics of Tanzania in implementing direct facility financing, the roles of local government authorities and health facilities and schools, they were separated relatively easy. There was a wave behind this. Now, how much was the wave? Was political will versus other factors? I don't know, but it was relatively easy, not too much controversy. Local governments had oversight and support roles. Very interestingly, and I think appropriately, local government finance department had a role in financial oversight and supporting facilities to implement new financial accounting and reporting systems. The health department focused more on clinical quality, education department more on education. The planning department supported the facilities to plan. The IT department supported facilities to operate IT. So this wasn't about health sector reform and massive donor investment in health. So the only important department at the local government was the health department, who subsumed all functions. It wasn't about that. It was about the entire local government beginning to function better. And local governments loved that the planning and budgeting and accounting and financial reporting systems were the same for all sectors. Again, health facilities, schools, but also the same for villages and agriculture. And that meant that they were more efficient. They could aggregate their reports for the national level, and they wouldn't have to chase sector standalone systems. And some of these functions were performed nationally, and it was seen as a positive thing to do so, including like Ministry of Finance internal audit being extended to the facility level. To go on a little bit more in discussing these roles, I think it's worth at least some comparison to global private business and its subsidiaries and operating units. No matter what the product, IT or cars or other, headquarters doesn't do all the business. Subsidiaries or their stores do much of the day-to-day management. Small public and private entities can be relatively similar in their operations, especially because accounting is so standardized, one of the more standardized disciplines in the entire world. A governance and management comparison the private sector is illuminating. Even people on the call, if you're working for a company or an agency, how many times do you meet directly with the board of directors? And they tell you what to do tomorrow. So again, this is this governance and management element. I do want to make one last comment about a specific Tanzania Health Summit had a joint government and DP direct facility financing DP field visit. And what you heard over and over from local government staff, I'm not saying necessarily the leadership, but technical staff, they got fewer complaints. People are happy. Their lives are easier. And very importantly for the health department, they could now form the critical clinical functions, especially important because some districts did not have many clinicians. Of course, it wasn't easy, but at some point it kind of settled into a continuous management improvement process. And I really do believe most Tanzanian stakeholders appreciated it, made their work easier, and they recognize that public providers must function well to deliver equitable and high quality public services.
So I think that's a good starting point, right? That fundamental agreement across all stakeholders that first and foremost, we want to improve service delivery. And then from what I'm hearing from both of you, finding that alignment perhaps between the interests of the local government. In the Kenyan case, you know, if you allow facilities to get some of this money from national programs, it's more money brought into the local health system. And even if the county doesn't control it directly, it benefits the county health system and reflects well on the county government. So finding those alignments, and I think telling the story effectively, the political story, also seems important. I'm now suddenly aware of the time, and I don't want to monopolize this entire discussion just with my questions. So I'm going to go to Gillian and ask Gillian to pull out some questions from the Q&A to pose to our two panelists. Thanks, Gillian.
Sure, thank you. So, I mean, first of all, there's a lot of just delight at the opportunity to have and hear this discussion. There's been several questions posed, and I'll just try to pull out a couple of key themes. So there's one around how we balance the need to provide facilities with autonomy while ensuring most cost-effective use of public funds. And some examples were given around purchasing drugs. How can we make sure that drug procurement remains cost-effective, whereas there might be a tendency to purchase more locally at higher prices under a facility autonomy process. And another one is around the risk of accountability mechanisms for DFF becoming a bottleneck. So I think we've seen in many countries that the flow of public funds can be quite a challenge. And does placing accountability mechanisms into that process slow down the flow of funds more, and can that have a more negative impact on service delivery? I'll start with those. Thanks.
Thanks so much, Gillian. Edwin, do you want to take a crack at either or both those questions, and then I'll come to you, Sheila, after that?
Yeah, quite very, very quickly. So the issue around, I think there's a question around balancing autonomy and efficiency, and the specific example it's an interesting example, and it always comes up, is around procurement.
Yeah.
Again, I think it's quite important for us to not look at these concepts or reforms as black and white. So when, for instance, we say that we have country contexts where facilities have procurement autonomy, it doesn't mean that then it means a central level of government does not have any role in procurement, for instance. I mean, I think it's quite clear, for instance, that, the role of central medical stores, pooled procurement has been recognized as efficiency enhancing and so on. And so when you look at the way countries have implemented procurement autonomy, it's really around allowing some flexibility at the facility level, one, to make their own decisions about procuring, including procuring from the central medical stores, and some form of flexibility to be able to procure locally when, for instance, different countries have different conditions. So for instance, some countries will say, well, you're allowed to procure locally when drugs are not available at the central medical store, or there is a threshold above which you cannot procure locally. So different conditionalities have been put around this to ensure that you have that balance, that on the one hand, you have the flexibility to ensure that drugs don't run out, and there's a timeliness in terms of a turnaround for delivery of drugs and so on. But at the same time, you benefit from, centralized procurement and supply chain and pooled procurement. So these are not black and white concepts. It's really, you have to design it to ensure that you're enhancing your goals rather than, sort of straitjacketing the reforms. On the issue around accountability mechanisms and whether there can be bottlenecks, again, one way to look at it is yes, we have seen instances where health facilities have been overburdened with reporting requirements and so on. But that's not a problem of direct facility financing. That's a problem of not using a sort of whole system, approach to reforms, right? If you are going to give facilities responsibilities to manage finances and require them to be accountable, then you have to make sure that they have what it takes for them to meet the accountability requirements. So the staffing, the systems, and so on. So if you do that, then again, you're likely to have that problem.
Great, thanks, Edwin. Sheila, any thoughts on these questions?
Yeah, I guess on the first question on the autonomy versus efficiency, it's a well taken point, but this is where, the devil's in the details, and certainly sequencing is critical, just like anything, any reform, any improvement, and sequencing usually involves some kind of segmentation here. So when you go through the options to segment, geography always pops up. Well, it certainly, based on my experience, is not to be recommended. No one wants this. The national government does not want pilots. They don't want certain regions prioritized. They want the entire country to be involved. Types of facility, that's happened in the past. Hospitals are okay, primary healthcare facilities are not recommended, also based on my experience. The one that it often comes down to is to segment by types of cost. And if you start small with basic supplies, and almost on an 80-20 rule of sorts, where you have 20% of the total money, but 80% of the transactions, and they're small and operational, I mean, I really can't think of too many cases where that's not efficient and operational, especially given transport costs, and especially given that the baseline for the efficiency measurement has to recognize the fact that half the time those facilities are not having patients to utilize services. So increasing efficiency over no utilization, or, we got to be careful how to measure this word in here. Now, on the drug one in particular, yes, I mean, this has been discussed a lot, was discussed a lot in Tanzania, and there's no reason that you can't have framework contracting. It's like moving towards facilities ordering, and then the money can be placed there and they can pay, but they're ordering within a broader framework contract or a prime vendor or whatever. There's a lot of ways to address that. The second question, lastly, at the start of financing facilities directly, and by the way, I'm going to answer another question that I saw in there, is this money was general revenue money in Tanzania. It was donor money, but it was budget support money. So it went through country systems. And that's the critical factor. That's what general revenue is. Whether it's domestic or international, it must go through country PFM systems. And then on the bottlenecks, I mean, you know, again, remember, I'm a finance person and it's a permanent debate. How much should finance people control versus how much you have program results like lives saved? This is a big game here when you're trying to save lives. And it's not only about financial control, but to be fair to business or financial management people like me, good financial management or PFM is supposed to help service delivery, not hurt it. And there are ways, obviously, to do that, and helping the facilities to manage helps to do that. On the audit provisions, we got to be real about this. You got external verification, which was the way of the world for a lot of things, pay for performance, RBF, initial PBF. I think it's becoming more integrated, but it was external versus country systems. And these country systems are the same throughout the world and in the private sector. There's audits. There's external audits and there's internal audits. Those audits should be built within the PFM framework and the overall systems. And by the way, nobody audits 100% of transactions these days. Nobody does that. You audit systems. So the idea that you're out there verifying or auditing everything, that's just not good financial management practice, which I think is another thing we need to hit head on. Over.
Thanks, Sheila. So I really like this idea of incrementalism in thinking about these reforms and implementing these reforms. And I feel like, so even as we have the principles that you've articulated so well in your work, that countries will pursue different journeys. And I think that, Edwin, ties in really nicely with your point as well. It depends so much on the context in the country, the politics of the country, and so the specifics will certainly vary. But at the same time, I've often wondered when we talk about, you know, primarily what the facilities control, initially at least, are the operating costs, right? That's what, you know, the operating budget is the operating cost. But the two biggest inputs into the production of services are going to be people and drugs. And so if we don't get to the point where they also have some control over those two big factors of production, as they say, then, you know, the operating costs will only get you so far. It's certainly important, you know, if the facility runs out of soap, can it buy it or not? But at some point, we need to also get to the commodities and we need to get to the people. So, so both are important. We need to be thinking about the long term, but starting small and building towards it. I know we're going to run out of time in exactly 3 minutes. So I want to come back and pose one final question to both of you. We've so far been kind of taking stock of what we know and what's happened. If you could reflect just for a second about where you think we should go from here. One sort of burning question, or what you think should be the priority as we, as a group of, you know, health financing folks who work on this at the global level or at the country level, what should we be prioritizing to move this agenda forward? And let me go to you, Sheila, first.
Yeah, I guess, you know, I'm going to stick with the management theme, you know, the potential of financing facilities directly to increase the emphasis on facility management and improve it, to differentiate and respect both governance and management functions, to recognize that governance and management or local government and service providers are not the same thing and work to both of their strengths. It's not either or, it's both. So specifically, to dig into further details, the specific roles and responsibilities and the relationship between entities primarily performing governance functions. Now that could be local government, or it could be a governing committee of a facility, but they have governance functions, and entities primarily performing management functions, including service providers such as health facilities and schools. Really dig into and unpack this, and maybe then that'll allay or address some of the politics underlying it. And then also, secondly, explore the potential for facility autonomy to actually improve public financial management, as it can lead to better separation of functions and better use of PFM systems and processes to manage service delivery. By the way, that is also the inherent in the question about Malawi, which is that, hey, better financial management is a good thing. and an investment in it is almost always a good thing. So, and it's the same is true as at facility levels. And a lot is known about this because it's not that much different in public and private sectors. Over.
Brilliant. Thanks. I really like that emphasis on, not having different rules for private and public, and certain basics are similar. And how do we borrow some of this thinking? I also really like the emphasis on distinguishing between functions and building out, what are the accountability governance functions that perhaps the local government plays versus the management functions at the facility level, and indeed perhaps at the county level as well, or district level. Edwin, your thoughts, and you're a researcher. What should we be exploring next? What are the burning questions that you think we should answer?
So, Nirmala, I only have two key things. One, I think it's quite important as people, contemplate on these issues as they debate on DFF and so on. It's really quite important for us to be able to draw from the lessons that already exist. So specifically, drawing on some of the lessons on direct facility financing to primary healthcare facilities, because those lessons are there. The reforms might not have been labeled DFF, but the lessons are there. And then more importantly, draw on lessons learned from initiatives to provide hospitals with autonomy, because there's a wealth of literature and evidence around the experience of doing that and what works and what doesn't and so on. So drawing on that to inform some of the ways in which we are innovating around PHC financing is really quite important. And then lastly, for me, again, is moving beyond the question, or adding on to the question on whether it works or not, and more importantly, focusing on, what are the conditions, under what conditions and what contexts, what are the design features of, financing facilities directly and autonomy that will enhance their potential to achieve the goals that we're interested in. So that to me is really what is more important, because it provides, levers for practitioners and implementers to design and refine their approaches to improving the way PHC is financed, rather than, the simple question on whether it works or not.
Works or not. Brilliant. Thanks so much. One lesson I've learned, I think, on this webinar is that we need more time. I see various people mentioning that in the chat box. So maybe the next one, Sheila, Edwin, we might get you back and have ask you for a little more of your time. But thanks, everyone. Thanks, first of all, Edwin and Sheila, for making time for this. I do want to note that this topic will be featured in upcoming events. One at IHEA, there are discussions planned where we will get into this commodities question, and that session is a virtual event. So even if you're not going to make it out to IHEA in person, you can join. And then I know, Sheila, you will be also leading discussions on this topic in the Montreux conference that's happening later this year. So we will have future opportunities to explore this further, but we will also plan on having slightly more time on the next Counterpoint webinar when we get into meaty discussions like this with top-notch people and thinkers and implementers from the field. So thank you all for joining today. Thanks everyone who've worked behind the scene to make this happen. Gillian and Caroline and Sheila, Edwin, thank you so much for making time for this.
Thank you everyone. Bye.
Bye. And we'll send the recording around for folks as well.
Thank you.
Bye-bye.